save some more time. We have to present. Is Dr. Gotte in?
Good.
Great, Marco. Thank you very much. So you're ready to present. So yes, indeed, we have to proceed to the next presentation as we face some problems with Professor Zwitter's presentation.
Can you hear me?
So, yes, of course. So,
okay, thanks. Cool.
So
I'm ready.
Yeah, so the title of your presentation is Catheter Imaging versus Active Tracking. So please start. Thank you very much.
Yeah, thank you for the invitation and an excellent meeting and an interesting topic, MRI-guided interventions. And I will spend some words on the way how we can track devices using MR. And there are different ways to do so. And you see on the slide our setup. In Amsterdam, we use an Avanto Fit scanner, and my colleague handling the catheters, maneuvering the catheters, is Cor Allard. He's the electrophysiologist, so it's a joint venture. And I'm the PI for the visible VT study. Why would we do anyways MRI-guided interventions? Well, cardiac interventions are performed frequently, and we are confronted with an increasing number of patients with increased complexity, which in general prolongs the procedural time. And sometimes we also need to repeat procedures in patients, in particular in children with congenital heart disease. And on the other hand, there's a development to strive for minimal invasive strategies. There are also targets for improvement, including radiation-free environment, but we also want to perform procedures faster and more precisely, preferably with less process steps and less interventions per patient. Okay, so for cardiac interventions, we are confronted with an increasing number of patients with increased complexity, which may prolong procedural time, and sometimes repeated procedures are needed. We need to improve this, preferably in a radiation-free environment, leading to faster and more precise procedures, maybe less interventions per patient. And also we strive to an imaging strategy with no need for contrast agents. And MR offers all these features actually. It's radiation-free, provides you highly detailed visualization of the heart and tissue. It allows you to real-time image what you're doing, and also it is possible to measure temperature and changes in temperature during procedures. So with better imaging, we are able to provide better clinical outcomes. That's the idea why we try to implement, develop, and expand the applications of interventional MR. So basically, we want to merge this situation, the conventional fluoroscopy situation, where we visualize catheters, but we can hardly see the soft tissue, the heart. We try to merge this with the excellent image qualities of what MR can bring you. And we've seen multiple examples this morning during excellent talks. There are different ways how you can visualize catheters or devices you need for your intervention. And the first and most simple strategy to visualize catheters or devices is passive catheter imaging. And what that means is that the imaging of a device, and this is a schematic representation of a MR-compatible guide wire, the device is visualized based on passive markers and characteristic of this particular device. And these markers create signal voids, black dots, and this is how you can visualize the position of the device. It's simple. It's an intrinsic property of the device. It generates signal voids on purpose, but it has no unique signal and image signatures. And operators, the person who is maneuvering the device and the imager, they have to work closely together to keep the device in sight. And this is an example of a MR-compatible guide wire. You can clearly observe the different markers in this static phantom, and new developments, new software developments, AI-driven developments try to come up with strategies that software is able to track the device and provide an overlay over the MR image to enhance visibility. This is one way to visualize a device in a patient. Another option is to use this strategy for MRI-guided biopsies. you have the bioptome, and you can apply these different markers on the shaft of the bioptome. It requires a redesign of the bioptome since it has to be made MR compatible. But once you have done so, you can also, based on the same principle, navigate the bioptome into the heart based on these passive markers. So there is no advanced technology, there's just real-time imaging or imaging in general. And based on the signal flows, you can visualize and localize the device within the heart. In addition, you can try to use AI software to generate a kind of overlay over these instruments visualized by the passive markers to improve the navigation and accuracy of navigating a bioptome, in this case, to a target area. And once you do so, you can increase the clinical yield of a biopsy. The downside is the redesign of the bioptome. What I mean is to make it MR compatible. The redesign of the bioptome also changed the intrinsic properties of the bioptome, so the torque and steerability are less compared to a conventional bioptome. So we have one that we can visualize it better and that we can visualize it integrated with the visualization of the heart. But the downside is that the maneuverability and the strength of the forceps are less, but still with an MR guided biopsy, the clinical yield is higher. However, this is not what we perform in Amsterdam, but it is a way how you can use passive tracking of devices, and it is low-hanging fruit. What we do in Amsterdam is another way of passive tracking. We use MRI-guided right heart caths. So what you can observe in this situation is a 4-chambered cine, and you can see the tip of the balloon of the Swan-Ganz catheter inflated with air. Air gives a signal void, which is clearly seen on the left panel. And we can maneuver the Swan-Ganz catheter based on real-time imaging through the heart, through the right ventricle, into the pulmonary artery, finally into a wedge. Of course, you can do right heart caths without imaging, but there's a reason why we do this. And it's not only because we can practice maneuvering and the interplay between the MR technologist and the imaging cardiologist with the person who handles the catheter in this case, but we can also extract more clinical relevant information from this. What we did is we took a MR400, MR compatible monitoring system, is one of the most common MR compatible systems to monitor patients who undergo an MRI scan. But the limitation of this system is that it has no data storage capabilities. So it's just meant to be used for monitoring, and it provides you instant information. The information is lost once it is not on the screen anymore. What we did is we have developed a strategy that we can capture the data, store the data, and play with the data. We have developed this pipeline, and we tested the pipeline in a phantom. So this is a deformable MR compatible phantom. We know exactly the change in volume and pressure, and we tested the setup we had developed and are willing to share with other sites to be able to record pressures obtained in the magnet. And the reason why we want to do this is that we create, based on the change in volume provided by MR and the pressures measured by the right heart cath, we intend to create pressure volume curves, and we can now create pressure volume curves from the different compartments, the right atrium, the right ventricle, the pulmonary artery, and wedge position. So surrogate for the left atrial pressures. For this purpose, we use an Edwards catheter, conventional Edwards catheter, which is MR compatible, with a drug sensor, a pressure sensor, which is MR compatible. We advance the catheter into the heart. We measure the pressures using the MR400, which is seen over here. This is the right ventricular pressure. We measure the change in pressure. We measure the change in volume. And based on this, we construct, this is the change in volume. Based on this, we are able to construct pressure volume loops. And this is an example of how we do this. So this is a real-time pressure volume loop created based on real-time imaging in one image plane. So it's 2D. Basically, it's the change in area, but it's the surrogate for the volume and the pressure. And we can acquire beat-to-beat change in pressures. And we can do this for the different compartments of the heart. So this is a step forward, since in particular for congenital heart disease, this can be very helpful in children. And again, we have found a solution how we can acquire the data, store the data, and play with the data to construct these pressure volume curves. And the navigation is based on passive tracking. So that's an advantage. Another strategy to guide instrument through the heart is active catheter imaging, and the previous speaker showed, but this requires advanced hardware and a redesign of the equipment we use for interventions. So this is, for instance, an ablation catheter from Imricor, and they have built in 2 coils in the tip of the catheter, so that's more advanced technology. It has implications for the design of the catheter, but these 2 coils are connected to the scanner and provide a bright signal on the image, as shown before. We pioneered this strategy basically and technology back in 2020, and this is in a pig where you can observe the bright signals coming from the 2 coils built in the tip of the catheter. Again, this requires a close collaboration and cooperation between the person responsible for the imaging and the person who is maneuvering the catheter, since you need manually to adjust the image planes to track the device advanced into the heart. So you need to know and understand the procedure, and basically you need to stay ahead as an imager, ahead of the interventionist. So you have to be prepared to provide him or her the next image. So it's quite challenging, and we practiced this multiple times before we did the first ablation, the flutter ablation, also in 2020 in a patient. And here you see how we maneuver the catheter, how it is positioned. It's not clearly seen on the images, but we were able to modify the signal strength coming from the 2 coils. So we know exactly which coil is the most distant coil, or what is the proximal coil, which is mandatory for the operator to understand in what direction he is pointing with his device. This is a way how we did it. And finally, we were able to advance the catheter into the coronary sinus and the second catheter for the ablation procedure in the right atrium. You can observe it over here. This is in the coronary sinus, and this is the other catheter used for the ablation. Another limitation of this strategy is that you cannot be sure that you can visualize both catheters at the same moment. It depends on the image plane where they are located, that you can visualize the 2 catheters. Another limitation at the beginning was that if you lose the catheter, so you cannot see it anymore because it is out of plane, you have to find it back manually, which is also an important limitation and requires a lot from the imaging team. Another aspect we encountered was the confusion. So basically, if you start doing interventional MR, it's a multidisciplinary team consisting of at least an imaging team and an interventional team, but they have a different way of looking to the world and using words to ask for something or indicate what they need. So that is the reason why we came up with this publication, highly recommended, where we try to bridge the gap between the world of imaging with the world of EP, and the different nomenclatures used for ablation strategies and for imaging are brought together to improve the understanding and help the navigation of devices. Then there is the latest kid on the block, I would say. So there's active catheter tracking, and for this purpose you have to create a shell. This is done at the beginning of the procedure, as explained by the previous speaker. You acquire a 3D data set. This is without gadolinium. Then you segment this data set, and you can upload this data set into the North Star system. So that's the navigation and mapping system. And basically you can take over control over the scanner using North Star. So it's not anymore the MR technologist who is instructing the scanner. No, the scanner is instructed via Northstar and based on the navigation keys provided by the system. So there's this 3D static shell, there are these image planes, and you can scan real time doing so. And there are two ways. This is active catheter tracking. So again, based on the corals built in the tip of the catheter, the scanner exactly knows where the catheter is positioned, and a rendered catheter is visualized on this 3D shell, and in the background you can see the real-time images. Here's another example how you can ablate. And the advantage is that you can rotate this image plane if you want to do so real-time in any orientation, so it's very adaptive. It's still the responsibility of the imaging team, but on the other hand, it closes the bridge between the conventional mapping and navigation systems based at the cath lab with the MR environment, gives more comfort to the interventionalist, and it also offers new avenues for MRI-guided interventions. I consider a static shell still a limitation, since if you have very complex anatomy, the heart is still beating and moving due to breathing of the patient. And in the case of complex anatomy, the static shell is not always helpful. And then we turn it off and fall back basically to the active catheter imaging strategy, where you visualize the catheter based on the signals coming from the corals. And it requires then more interaction between the operator and the imaging team, but it gives you a more real-time feeling of where the catheter is positioned and how the structures are related into each other. These are differences between the different techniques. So passive, you can basically track just one device, and you need to track the device manually, so it requires a lot from the operator. The tracking rate is approximately 7 to 10 frames per second, but the advantage is there's no additional software required, there's no scanner interface required, everyone can do it tomorrow. There's an issue with heating, since if you continuously scan real time, you use a lot of energy. The noise is also an issue, since the operator, although with air protection, is aware of the noise, and there's no interrupted scanning possible. You have to scan continuously to track the device, and I will come to this in a minute. Active catheter tracking, it allows you to track more than one device. It's real time, so particularly if you do the active catheter tracking, the temporal resolution is very high, since you only track the position of the catheter, which does not cost many time, so your frame rate or your refresh rate is way higher than conventional scanning, so that gives you a more accurate position of the device. But you need additional software, in this case a navigation system like Northstar, and importantly you need a software tool which allows you to connect the scanner with this third-party software. And for Siemens this is XSI. This is already certified and exists for many years. Philips at this moment has no certified interface. They are working on the interface. It's called Comrade, and it is expected to be launched next year with the upgrade of the software platform to V12. But today, it's not possible if you have a Philips scanner to connect with Northstar. The advantage is that it is just partly operator dependent. You still need an operator to manipulate scan strategy using Northstar, but it is more natural in terms of how we do this in conventional fluoroscopy environment. It requires this 3D static shell. I think a deformable shell would be better contribute to the outcome, but this is at the moment not possible. Heating is less an issue. Noise is no issue, since we only run then tracking corals. And for electrophysiologists, it is essential that you have a clean EKG. So what this strategy offers you is that you can also scan in burst, or in other words, you can apply interrupted scanning, which means that there are short bursts of scanning to localize the catheter, and then there's a pause, and within this pause there's no distortion of the EKG besides the magnetodynamic effect. So it offers the electrophysiologist a better assessment of the electrical situation at that moment. Basically, this is it regarding the strategies for tracking devices. And novel applications are the transeptal puncture sheath. You need this if you want to have access to the left side of the heart and start doing ventricular ablations. And we are lining up for this. We have done the first ventricular ablation a couple months ago, and I will present on this later this day. But this is the same principle. This is the sheath, and there are two coils built in the tip of the sheath, and based on the signals coming from the coils built in the tip of the sheath, you can navigate the sheath into position to puncture the septum. And this is how we did this in a pig, and we did this multiple times to prepare ourselves to do this in human. We were very successful in navigating the sheath into position to allow the interventionalist to puncture the septum at the right location, as demonstrated over here. And you can observe over here that the catheter is located in the left atrium. So this is a new application. So to summarize, device tracking, this can be done passively based on intrinsic properties of the device itself. Easy. I would recommend start doing this tomorrow, since you need to train your team to be prepared for doing more complex procedures. You can continue with active catheter imaging. It requires additional software which allows you to connect the coils with the scanner. So in the Siemens case, it is XSI. In the near future for Philips, it is Comrade. And finally, you can connect this to a on-purpose navigation system like Northstar. And then you can take over the control of the scanner, and it feels more convenient for the interventionist to perform ablation procedures. This is the overview of the current situation regarding tracking. Thank you for your attention.
Thank you very much, Dr. Gotte, for your nice and innovative presentation. It's nice. Because Vitor is also with us now. Okay, great. So I was very carefully listening to your presentation, and it's clear that we are entering a new era in this, let's say, very promising technology. Although, for somebody like me, quite experienced, but not such advanced to understand all the details of the interventional CMR technologies, a number of questions and concerns are.
That's important too.
Yeah. My first reaction here is how much, in many countries, electrophysiologists will be dependent from the imaging persons. You see, in Europe, so far, in most of the countries, the radiologists are the kings of MRI too. And this is a very big issue for cardiologists, even the most experienced of those, like Dr. Mavrogeni. So, and as you know, I'm sure that the same is in Amsterdam. By the opportunity, you are working with my good friend Volker Asselbergs there. Okay, so everywhere the radiologists at the moment have let's say a very
they do have a very strong position. In general, the MR scanners are based and under control of the Department of Radiology.
So you need here you need indeed an ideal collaboration, by heart collaboration, very kind collaboration between radiologists and cardiologists and electrophysiologists. And
to be honest, in Amsterdam, there's no radiologist involved. So this is a purely cardiology-driven situation, but we use a conventional diagnostic scanner. It's an old scanner, Avanto Fit system. It's based...
How many Tesla is this one?
I'm sorry?
1.5.
1.5. 1.5.
Okay. Anyway,
what we did is we pay the Department of Radiology for the use of the scanner. So we basically hire the scanner for the day that we perform ablation procedures, and this gives us a kind of independency. Currently, a new cath lab environment is constructed in Amsterdam, including 9 cath labs and also 1 dedicated MR facility for cardiac intervention. So it's if you start today, you will be confronted with the situation that you have to use the conventional scanner and you have to deal with radiology. But I think there's also the interest of radiology. It's growing, since the technology I've shown can also be applied for ablations for tumors, can be used for great vessel interventions. So there is some mutual interest. But if you solve the problems for cardiology in cardiac interventions, they are the consequence is that you basically also solve problems for more simple interventions, like static structures, which you try to treat with a device.
We have to accept that in each country there is a totally different reality, okay? And these realities are mostly economic oriented and professional, narrow professional and let's say poor professional attitudes. But anyway, this is another story. Let's go now to another, and my last comment here among the many others is, I was pondering as I saw your presentation now and the slides, but also before, as myself as an ablationist, for example, using cardiac magnetic resonance, do I have the opportunity in some special and complex cases with fibrotic tissue to have better visualization of the area of the ablation? Because the MRI technique. You understand my question? For example, I have to ablate an area of ventricular tachycardia, okay? Using the traditional mapping techniques, I know where to ablate, more or less. But as MRI has, as far as I know, the opportunity to visualize much more clearly the fibrotic area, does it mean that I have the opportunity using this system to ablate more precisely the fibrotic area?
There are 3 aspects related to MRI-guided ablations, and all are related to the outcome. So what determines the clinical outcome of an interventional procedure? It's the accuracy of navigating your device to the target area. And I think with this new opportunity, using MR for navigating your device into position to target it to an area you want to treat, improves the clinical outcome. That's inevitable. You can clearly see where you are, and I think this is one of the limitations of performing procedures under fluoroscopy. So the accuracy of navigation is one driver of improving the outcome. The second reason why this improves or potentially improves the clinical outcome is you have a more direct feedback on your therapy. So ablation is nothing else than tissue modification, and MR is the only imaging modality which by nature can provide you tissue characteristics and changes in tissue characteristics. So we are now pioneering 2 strategies. One is the real-time temperature mapping and the change in temperature of the tissue while you are ablating. So that's a measure for the energy delivery, and we can visualize the lesion created while the catheter is still in place. So we have a way better insight in the impact of the ablation itself. And we are pioneering improving imaging strategies, which are non-gadolinium based, so there's no contrast needed, but gives us insight in what kind of lesion we do have created, and is this a durable lesion or a temporal lesion. And since we now get a better understanding of is this a durable or a temporal lesion, we can during the procedure modify the strategy to make sure that we end with durable lesions and no gaps in conduction lines, for instance.
Okay.
So that's why I think that we should continue what we are doing. Although it is a struggle, it is cumbersome, the relationship with radiology, the access to the scanner, the equipment you need, but ultimately it will improve the clinical outcome in a way that cannot be offered by the conventional strategy in fluoroscopy environment.
Professor Zweiter?
Yeah, what I would like to say to that is, yeah, I'm fully in agreement with Marco Gotte's comments. And I think there was a very good study from Barcelona. They did ventricular ablations, conventional ones. Then in another arm, they added information from the MR machine, so late enhancement, the scar distribution. And in the third arm, they just used the information of the MR, and the information of the MR, the scar distribution, was added to the mapping system, and they burned based on this information. So it was like a conventional arm, MR-aided arm, and a pure MR-guided arm. So the intervention was done in the conventional electrophysiology lab, but the information was transmitted from the MR scanner, not in real time, but it was overlapped, the mapping system with the scar distribution. And in that study, they had a shorter intervention time in the third arm, and they had significantly less relapses in the third arm. So they performed much better in the third arm compared to the other two arms. It was not blinded, of course, and it was, I think, about 30 patients. So it's a preliminary study, but they could clearly show that there are advantages of MR, like Marco Gotte mentioned, and this translates in better outcomes and shorter intervention times, and of course, no radiation at all at the end of the procedure. And it was not done in the MR lab. So there are still a few steps that transfer the data from MR into the laboratory of electrophysiology with some misregistration issues, etc. So it's not the full exploitation of the technique. So if you go purely, entirely into the MR lab to do these interventions, I think the results could be even better. I would expect would be better than what the Barcelona group showed. But even with this transfer of information, the procedure time was shorter, the relapse time was less, relapse number was less, so much better outcome. And this is a very good study and a very encouraging study.
So, Professor Zweiter, Professor Gotte, just to summarize in very brief, as the audience possibly is not so much aware about this new technology. Somebody could speculate here that using a cardiac MRI techniques versus the conventional imaging has, one, less radiation for sure.
No radiation. No, complete no radiation.
No radiation, okay. Second, cardiac MRI could be combined with the classical electroanatomical systems to map classically the area for ablation, plus the fact that using MRI, you could, additionally to the classical, traditional, conventional mapping, electrophysiological mapping, to locate, to identify the arrhythmia substrate much more clearly using at least in some cases, where the substrate involves fibrosis, because the MRI system. Is this correct?
Yes.
This is correct. It is a more comprehensive strategy, and it offers you the tissue characteristics and the modification of the tissue characteristics while you're ablating.
Yeah, and then you can see the results and the outcomes, no doubt. But I try to summarize 3 main areas and topics where this new technique and technology is looking for. Zero fluoroscopy time, a complementary mapping using electroanatomical systems, but also the fibrotic characteristics, and then, of course, to check the outcome of the ablation.
Correct.
Yeah.
If somebody likes to summarize in very brief the concept of this technique.
One more question. Can we identify also the gray area around the scar, and maybe we can include information from diffuse fibrosis in a mixed polar map in order to know, because in some patients we don't have a special LG area, but we have diffuse fibrosis and still have ventricular tachycardias. Can we get this information in a total map including localized and diffuse fibrosis?
This requires a scan prior to the ablation procedure, since once you have administered contrast, you cannot re-evaluate the lesions you have created. The second thing, difficulty is basically all technology is available, but the integration, including fast processing of image data and give the data, the information provided by the image data back to the interventionalist, this is not yet optimal in place. This is research, but yes, ultimately we will have this situation that you have a very detailed assessment of the arrhythmic characteristics of the tissue, hopefully without the need of gadolinium, and a direct feedback on the manipulation, the ablation applied to change the characteristics. This is the potential. And now we are at the stage that we have basic equipment that allows multiple sites to start, to pioneer. We need more sites to participate. We need a higher critical mass, I would say so, to get more experience as a community. But it's now the time to start doing so, to step in. We have pioneered without North Star and very rudimentary situation, how we could visualize devices, etc., etc. If you start today, you will have a navigation system. You feel familiar with it. The catheters are easily projected, so the navigation part is now at a high level. We have to invest in how can we use the image data in line during the procedure itself. And that's where we are working on this. Other sites are working on this, but we need more sites to do so.
Okay, thank you.
Great. So I think we have to proceed now to